Welcome to this comprehensive overview of malnutrition in Ethiopia, designed specifically for medical students. In this video, we will explore the scale, causes, and consequences of malnutrition, as well as the clinical and public health implications for Ethiopia. Understanding these concepts is crucial for future clinicians, as malnutrition remains a leading cause of morbidity and mortality among children and women in the country. We'll start by defining the core indicators of malnutrition, then move into epidemiological patterns, clinical consequences, and finally, practical approaches for intervention and prevention. Let's begin our journey into this critical public health topic. Ethiopia faces one of the most severe malnutrition burdens in sub-Saharan Africa. For medical students, understanding the scope of this issue is essential for effective clinical decision-making and public health action. The prevalence of malnutrition affects not only children but also women, perpetuating a cycle of poor health outcomes. National surveys reveal that stunting, wasting, and underweight remain widespread, though some progress has been made over the past 2 decades. Recognizing these patterns helps clinicians tailor interventions to the needs of their communities. The 3 primary anthropometric indicators used to monitor child nutritional status are stunting, wasting, and underweight. Stunting reflects chronic malnutrition and is measured by height for age. Wasting indicates acute malnutrition, measured by weight for height, and underweight is a composite indicator reflecting both acute and chronic malnutrition. In Ethiopia, stunting affects about 40% of children, wasting about 5%, and underweight about 18%. These numbers have decreased since 2000, but the burden remains high. Early identification and intervention are key to preventing irreversible damage. The first 1,000 days from conception to a child's second birthday are critical for growth and development. Malnutrition during this period can cause irreversible cognitive and physical damage. Ethiopian nutrition policy prioritizes interventions during this window to prevent stunting and its long-term consequences. Medical students should recognize the importance of early nutritional support for both mothers and infants, as interventions after age 2 cannot fully reverse earlier deficits. Current wasting and stunting, known as WASINT, describes children who suffer from both acute and chronic malnutrition. This group faces a much higher risk of mortality than those with only one form of malnutrition. In Ethiopia, WASINT affects nearly 5% of children under 5, with higher prevalence in rural areas and among boys. Factors such as low birth weight, recent illness, and lack of vaccination increase vulnerability. Clinicians must identify and aggressively manage these high-risk children to reduce mortality. Children with concurrent wasting and stunting are at exponentially higher risk of death from common infections like diarrhea, pneumonia, and measles. This makes early detection and aggressive nutritional rehabilitation essential. Medical students should be aware that these children require close clinical monitoring and tailored interventions. The presence of WASINT is a clinical red flag, signaling the need for urgent action to prevent fatal outcomes. Maternal malnutrition is both a cause and consequence of poverty and food insecurity. When mothers are undernourished, they are more likely to give birth to low birth weight infants, perpetuating a cycle of malnutrition across generations. In Ethiopia, over 21% of women are underweight, and more than a quarter of pregnant women are anemic. Addressing maternal nutrition is essential for breaking this cycle and improving outcomes for both mothers and children. Access to antenatal care, ANC, is vital for identifying and managing maternal malnutrition. However, only about half of Ethiopian pregnant women attend the recommended 4 or more ANC visits. This limits opportunities for nutritional screening and supplementation. Improving ANC coverage is a public health priority, as it can significantly reduce maternal and neonatal complications related to malnutrition. Malnutrition in Ethiopia varies significantly by region. For example, Oromia faces a triple burden of overweight, stunting, and iron deficiency, while Amhara and Tigray struggle with stunting and micronutrient deficiencies. Urban areas like Addis Ababa are seeing rising rates of obesity alongside persistent micronutrient gaps. Clinicians must understand the local nutritional landscape to provide effective care and counseling. Ethiopia is experiencing a nutrition transition, with both undernutrition and overnutrition present in the same communities. The double burden refers to the coexistence of undernutrition and overnutrition, while the triple burden adds micronutrient deficiencies to the mix. This complexity requires integrated interventions that address all forms of malnutrition simultaneously. Geospatial factors, such as soil nutrient density, influence regional patterns of malnutrition. For example, low soil nitrogen is associated with higher rates of iron and zinc deficiency. This highlights the importance of nutrition-sensitive agricultural strategies, including the use of appropriate fertilizers, to improve food quality and nutritional outcomes. The Ethiopian Demographic and Health Survey, EDHS, provides essential data for tracking nutrition trends. Key indicators include stunting, wasting, exclusive breastfeeding, dietary diversity, and micronutrient coverage. Medical students should be familiar with these metrics to evaluate progress and identify persistent challenges in their communities. Ethiopia has made progress in reducing stunting and wasting over the past 2 decades. However, regional disparities and high rates of micronutrient deficiencies persist. Continued efforts are needed to close these gaps and ensure equitable nutrition for all children and women across the country. Malnutrition is not just a health issue, it's an economic crisis. Child undernutrition costs Ethiopia an estimated 16.5% of its GDP, equivalent to the combined national budgets for health and education. These losses stem from reduced productivity, increased healthcare costs, and impaired cognitive development, perpetuating poverty across generations. Undernutrition is a leading cause of child mortality in Ethiopia, contributing to nearly half of all deaths under age 5. Malnutrition weakens the immune system, increasing vulnerability to infections like diarrhea, pneumonia, and measles. Early identification and management of malnutrition can save countless young lives. The impact of childhood malnutrition extends far beyond early years. Stunted children are more likely to have cognitive impairment, repeat grades in school, and earn less as adults. These effects contribute to a cycle of poverty and poor health that can last generations. Interventions during early childhood are crucial for breaking this cycle. Malnutrition is transmitted across generations. A stunted adolescent girl is more likely to have complications during pregnancy and give birth to a low birth weight infant. This infant is at higher risk of stunting and poor development, perpetuating the cycle. Addressing adolescent and maternal nutrition is key to breaking this pattern. Vitamin A deficiency is a major public health problem in Ethiopia, affecting over 60% of children under 5. It leads to night blindness, increased risk of infection, and even death. National programs provide high-dose vitamin A supplements, but coverage remains below optimal levels. Early detection and supplementation are critical. Iron deficiency anemia is widespread in Ethiopia, especially among women and children. It causes fatigue, impaired cognitive development, and increased maternal mortality. Folate and vitamin B12 deficiencies often coexist, making anemia a multifactorial problem. National guidelines recommend iron folic acid supplementation for pregnant women. Iodine deficiency remains a significant issue, especially in highland regions. It causes goiter, intellectual disability, and cretinism. Despite a national salt iodization program, coverage is still inadequate. Clinicians should always check for goiter in patients from endemic areas and counsel on the use of iodized salt. Zinc deficiency is common and contributes to increased severity and duration of diarrheal disease in children. Zinc supplementation is now part of national guidelines for managing diarrhea, but utilization remains low. Educating mothers and ensuring access to zinc can reduce child mortality and improve recovery. Folate and vitamin B12 deficiencies are highly prevalent, especially among women and children. These deficiencies contribute to anemia and neural tube defects. National surveys show that nearly half of pregnant women have folate deficiency. Food fortification and supplementation are important strategies for prevention. Micronutrient deficiencies, often called hidden hunger, affect even children who appear well-nourished. Deficiencies in vitamin A, iron, iodine, zinc, folate, and B12 can cause serious health problems. Medical students must be vigilant in screening for and addressing these deficiencies in clinical practice. As a future clinician, remember these key messages. Know the numbers. Stunting, wasting, and wasting are not just statistics but real patients. Regional context matters and interventions must be tailored. Malnutrition kills and micronutrient deficiencies are often hidden. Addressing maternal and adolescent nutrition is crucial for breaking the cycle. Early intervention, especially in the first 1,000 days, is vital for lifelong health. Interventions work. Vitamin A supplementation reduces child mortality by up to 30%. Zinc supplementation decreases diarrhea severity and duration. Iron folic acid and multiple micronutrient supplements improve maternal and child outcomes. As a clinician, your role in diagnosis, counseling, and public health action is critical to achieving national nutrition goals. To reinforce your understanding, consider these practice questions. How do you diagnose WASN? What supplementation is recommended for pregnant women with anemia? How do you manage a child with diarrhea? These scenarios reflect real-life clinical challenges you will face. Reviewing them will help you apply your knowledge in practice.